So I'm Jill Kiernan. I'm the founder and executive director of the Tatten Brown Raman syndrome community. And I am really grateful to have Dr. Rachel Rao with us today. Um, she's an esteemed member of our scientific and medical advisory committee and has been with us right from the start practically of the TBRS community. And not only is she an incredibly talented researcher and physician, but she's also got the kindest heart of anybody I know. She's in this for the right reasons, and she really loves our kids. So now I'll do her more formal introduction and say Dr. Rao is an associate professor of pediatrics at the University of Washington and a board certified pediatric hematologist oncologist at Seattle Children's Hospital. Her lab-based research program is focused on understanding the molecular mechanisms that cause leukemia and treatment resistance with the aim of translating these findings into clinical applications. She has a special focus on the effects of DNMT3A mutations on blood development and cancer risk. She also works to bring novel treatments to children with leukemia through her work with the Children's Oncology Group, which is the largest pediatric cancer consortium in the world. She has led 5 Children's Oncology Group clinical trials and is currently the chair of biology of the Children's Oncology Group Leukemia Committee. So, Dr. Rao, again, thank you so much. And why don't you go ahead and start your presentation? And what are you? Do you have a hard stop time?
Well, I was just going to ask you. I do not.
Mm-hmm.
So, how much time
Okay.
is allotted for this, Jill?
So I would say definitely until 6, and then if people still have a lot of questions and you're available to continue, then that's great. And if not, we could always follow up with you after as well.
Yeah, that's fantastic. Great. I do not have
Okay.
a hard stop, but I want to be mindful of everyone's time, especially as I can tell already, just with the faces I can see that we're in multiple different time zones, probably around the world. So it's 2 p.m. here, which is a fine time to chat. But I know if it's 9 p.m., maybe you don't want to stay on for multiple hours. So as Jill very kindly introduced me, I'm a pediatric blood and cancer doctor at Seattle Children's Hospital in Seattle, Washington in the United States. I just moved here a couple of years ago after having spent over a decade in Texas at Texas Children's Hospital. So I'm very glad to be here. I've done a similar talk a couple of years ago, and if you were present for that talk, some of this is the same, but there is some new content, particularly at the end. So hang in with me. If you get a little bored in the first part, there's new stuff at the end. I do want to just start out by saying this is an incredibly heavy topic, and some of the things that I was asked to talk about can be, somewhat startling and scary to hear about. I just want to, say this is all for information purposes only. And because this is a scary topic, I always start with this statement. Cancer is not an inevitable consequence of having a DNMT3 mutation. After sort of looking through the literature, the rich data we have gotten from the TBRS registry, from animal models of TBRS, that's the basis for the statement that I feel confident in making. That said, I think it's important to understand what cancer is and what the potential risk might be for your loved one with TBRS. But I just want to start by saying I don't think it is going to happen to most. I think actually most people with TBRS will never get cancer. But I just want to, sort of lay out some things to be aware of, to think about for your loved one. I'll also say that I can keep this relatively informal. Please put questions in the chat when they pop into your mind, because you may not hang on to them until the end. I am going to pause midway through for questions. Maybe we can address some things that have popped up in the chat. And then again, at the end, I'm happy to hang around for as long as folks are hanging around for questions. We'll address as many as we can get to. Okay, so just a quick outline of sort of what I'm going to try to cover this evening. First, I'll talk about sort of the role of DNMT3A in normal blood development. That'll sort of set the stage for thinking about what abnormalities can occur in individuals with DNMT3A mutations associated with their blood. including the possibility of blood cancers called leukemias. And then we'll sort of wrap it up with thinking about a few other cancers that have been reported in individuals with TBRS and thinking through what other risk might be out there. So just as a primer on sort of how our normal blood develops, all of our blood is made in that hollow part in the middle of our bones called the bone marrow. If you've ever broken apart a chicken bone and seen the inside of it, it's you've got the hard bone on the outside and then a soft, spongy middle in the middle. And our bones are not unlike chickens. We have that bone marrow in the middle, and that is where all of our blood cells are made. And under normal circumstances, the development of blood cells is a very orderly process that's sort of organized through this hierarchy, starting with this very specialized cell called the blood stem cell. And the blood stem cell is special in that it can both make new copies of itself every once in a while, so pretty rarely, or it can specially differentiate, make a new cell that can ultimately form all the blood cells that we need to survive. And there are a bunch of different types of cells in our blood that help us survive, and we'll sort of walk through those. We know from work in our lab and lots of other labs that normal DNMT3A plays a very critical role in orchestrating this whole process from stem cell all the way through all the normal blood cells. It helps us turn genes on that we need to be turned on at the right time, turn other genes off that need to be turned off at the right time to allow this process to occur normally. So just to sort of go through all the different blood cells that we have floating around in our blood, helping us to survive, we'll start with the red blood cells. That's the fancy word for it there, erythrocytes, but I'll just call it red blood cells. These are the cells that go to our lungs, pick up oxygen, and carry them to the rest of our body, providing oxygen to all of our tissues, our heart, our brain, our muscles, our skin. So these are obviously important for that purpose. Next over are our blood platelets. Platelets are small little cell fragments that if you get a cut, they're the first thing that arrives to plug up that hole to stop the bleeding. Next over is this set of cells called white blood cells. And there are a whole bunch of different types of white blood cells. These are responsible for helping our body to fight off infections. They're what arise to the occasion when you experience a bacteria or you encounter a virus. These are the cells that help your body clear those things and keep you healthy. So of course, no process is perfect. Things can go awry as these cells are making their way through these pathways. And so several different blood abnormalities can occur in individuals, not specific to TBRS individuals, but just blood issues that can arise. Some people can experience something called anemia, where you have low amounts of red blood cells. So you're not having enough of them to carry oxygen adequately to all of your tissues. So these people are very pale, they're run down, they get very short of breath after walking just short distances, for instance, because their body is deprived of the oxygen that normally would be carried to the body by those red blood cells. If you have a problem with your platelets, if they don't work right, or if you don't have enough of them, you might be prone to bleeding. You don't have enough of them to plug up those holes when you get a cut to your skin, for instance. Conversely, sometimes your platelets can sort of be overactive, and that might predispose you to forming blood clots in your vessels. And then, of course, with all of these different white blood cells, different problems can occur. But if you have problems with your white blood cells, be they not enough of them or they don't work properly, then you might be prone to recurrent infections or really bad infections. Additionally, these are the cells that if they get too overactivated, they can cause inflammation in your body. They release things that are designed to kill bacteria and destroy viruses, but if left unchecked, those things that they release to kill bacteria or destroy viruses can actually damage the tissues of your own body. So that's called inflammation. They can also be a little bit just too hypersensitive to the things in our environment and cause allergies. If you've ever had hay fever during the spring, that's because your white blood cells have overreacted to some of the pollen in the air. And then there's another set of disorders that can occur called autoimmune diseases. That's when your own white blood cells recognize parts of your body as foreign and start to attack them. These are rare situations, but ones that can be caused by abnormal functioning of the white blood cells. And of course, on the most extreme example of how blood cells can go awry are the blood cancers, which we call leukemia. And there are two major types of what we call acute leukemia, acute myeloid and acute lymphoid, depending on which type of white blood cell they started to arise from. But these are cancers of the blood cells. And what a cancer is just something bad has happened to a cell on its way to becoming a mature normal cell. And that bad thing has caused the cell to grow too much. It makes way too many copies of itself, and it just doesn't mature normally. So it doesn't function like a normal white blood cell. It might look like kind of a white blood cell under the microscope, but it doesn't have a function. It doesn't work. And it just makes so many of itself that it crowds out all the normal blood cells that should be developing. And that's what can cause the symptoms of those diseases. So how does this relate to TBRS? Well, I first got interested in DNMT3A, which is, of course, the gene that's mutated in all the cells in the body of a person with TBRS, because DNMT3A mutations were found to occur in cells that were cancer cells, in leukemia cells of patients with different types of blood cancers. And you can see here just a spectrum of different types of leukemias, so acute myeloid leukemia, and then there are a whole bunch of different types of leukemias that can develop. One timer, sorry. And you can see varying frequencies, up to almost a quarter of patients with certain types of leukemias will have DNMT3A mutations in just their leukemia cells. Interestingly, oh, sorry, I think I'm on a timer now. While the mutations are common in blood cancers of adults, they're really rare in blood cancers of children. So if you look at sort of the similar spectrum of leukemias that can occur in children, we almost never see DNMT3 mutations, which means that for patients who have gotten a DNMT3 mutation, it either doesn't happen until later in life, or it takes a really long time from the time you've gotten that mutation to actually develop cancer, which means you probably need to have multiple bad things happen to that cell. Just DNMT3 mutation by itself probably isn't enough to make it a cancer cell. The other reason we know that DNMT3 mutations by themselves are not enough to cause leukemia is because if you looked really carefully in the blood of otherwise normal, healthy, happy people, even if you took blood from me right now, you may very well find some cells with DNMT3A mutations. If you sequence deeply enough, meaning do a special test where you look at the DNA and look at lots and lots and lots of cells' DNA, you'll find DNMT3A mutations in almost all adult people walking around right now at very, very low levels for the most part. And this process is a disorder called clonal hematopoiesis. And what that means is that one of our blood cells picked up a mutation, most commonly in DNMT3A, along the way during our lifespan. And that DNMT3 mutation gave that blood cell a slight advantage over the other blood cells. So it makes new copies of itself with a higher frequency than blood cells without that mutation. And if allowed to go on long enough, you can detect those mutations if you just take a blood sample from an otherwise healthy person. Now, even if you have relatively high amounts of DNMT3 mutation detected in your blood, most people with that problem will not ever develop a blood cancer. Less than 5% of people who have a relatively high level of DNMT3A mutations detected in their blood will ever go on to develop cancer. Again, suggesting DNMT3A mutation by itself isn't enough to cause leukemia. There probably have to be multiple other things happen to those cells over time to bump them from being relatively normal blood cells to cancer blood cells. So one of the questions that we were interested in some years ago when I was still in Texas in the lab is, so we know that DNMT3 mutations can occur in blood cancers. And now we know that there are individuals with Tatten-Brown-Raman syndrome who have DNMT3 mutations in every cell in their body, including their blood cells. Does that mutation cause differences in their blood compared to other people's blood? So to do this, I worked with a postdoc at Baylor at the time, Ayala Toby, who's now moved on to work in Boston. She's doing great things. But we worked on a project in which we collected blood from individuals with TBRS really all around the world. And we asked the question, is that blood different than individuals who don't have TBRS? So to do this, it took a lot of time and a lot of effort and a lot of collaboration with the TBRS community. Huge thanks to Jill and others who really helped with this effort. We were able to collect blood samples from 18 individuals with TBRS, ranging in age from 2 to 38 years, from really all over the world. You'll see the little tacks there for the different places in the world we were able to get blood samples from. And then we did special tests on those blood samples that we received. In addition, we had 11 individuals without TBRS. Most of them were brothers and sisters of the individuals with TBRS, which we considered the best control population for our TBRS individuals. And then we had 4 healthy, unrelated individuals of the same age range. So we worked with some of our pathologists at Texas Children's, the hospital I was at the time, to do a special test in which we could really, with a great level of detail, understand what types of blood cells were there, how many of them were there, and how they differed in TBRS individuals compared to those without TBRS. And I'll just sort of walk through going one by one through those different cell types that we talked about at the beginning and what we found. First off, what we found is that for the most part, there were not big differences in the blood of individuals with TBRS compared to those without TBRS. In fact, most of the parameters we looked at in individuals with TBRS were well within a normal range. So that was somewhat surprising. We know DNMT3A plays a very important role in regulating normal blood development. But having one normal copy of DNMT3A seems to be enough to maintain relatively normal blood production for individuals with TBRS. But we did find some subtle differences that are worth noting. Number one, when we looked at the individuals with TBRS red blood cells, so that oxygen-carrying blood cell, oh, sorry, that turned out a little blurry there. We noticed that they were not anemic overall. Now, in the registry, we see some reports of individuals with TBRS having anemia, but we didn't find that in our study based on relatively small numbers of individuals. But overall, anemia does not seem to be incredibly common in individuals with TBRS. We saw that the total number of red blood cells was the same as those without TBRS. The hemoglobin level, which is the part of the red blood cells that carries oxygen around, was in normal levels in individuals with TBRS. So we did not find a significant association with anemia. What we did find is that what we know is red blood cells can range in size. It can be relatively small or relatively big or sort of anywhere on the spectrum of size. And we found that the red blood cells tended to be larger in the individuals with TBRS compared to those without. Now, we know that there's a pretty broad range of what we consider normal. And while the siblings of the TBRS individuals were sort of in that tight middle of that range, we saw that our TBRS individuals were skewed to sort of the larger size, with very few of them falling outside of the actual normal range, but just being on average larger than those without TBRS. So this is interesting, but I suspect a benign finding, meaning something that probably doesn't cause issues for individuals with TBRS. We actually see a very similar thing in individuals with a different genetic syndrome called Down syndrome. They tend to have larger red blood cells, but they work perfectly fine. They're not anemic. They just have this distinct feature of their blood cells. So what I'll say about this is I don't think it's a disorder or a disease, but I think it's important to know if this is your normal. Because if you come in at a time when you're feeling sick, having symptoms, and a doctor checks your blood and sees that your red blood cells are slightly large, that might prompt a whole bunch of workups that were unnecessary if you knew that's just your normal red blood cell size all along. So we'll get to some suggestions at the end here, but I think it's important to sort of, what is your normal? When you're not sick, when you're feeling fine, what is your normal red blood cell size? That might prevent a lot of unnecessary workup down the line. So I'll skip over the platelets because we did not see any differences in the platelets of our TBRS individuals compared to non-TBRS individuals in terms of number or size or other factors or features. We could not test the function of the platelets, so that's still something that we don't know. We don't know if they work exactly the same, but we know in terms of shape, size, number, they were not different in our TBRS individuals compared to those without. But the white blood cells, again, there are a whole bunch of different types of them. We did see some very distinct differences in our TBRS individuals compared to those without. Okay, there are a whole bunch of different types of white blood cells, and they all generally fight infection, but they do so in different ways. So we'll sort of walk through the ones that we saw as different in our TBRS individuals compared to without. So number one, was we noted a higher percentage of a cell type called neutrophils in the blood of individuals with TBRS compared to individuals without TBRS. What are neutrophils? So they're sort of a primitive type of white blood cell. They just sort of react in a nondescript way to anything. It's like an alarm bell goes off and they just are called into action. So if you are exposed to, say, a bacteria that causes some inflammation, that's a danger signal, and that sends the neutrophil into action. And essentially they can do a couple of things. They can catch and destroy the bacteria, and they can just release a whole bunch of toxic things from inside the cell. And that release can lead to that inflammation we talked about. And it can recruit other types of white blood cells to help fight off that infection. So they're both trying to do their best to kill as many bacteria as they can, but they're also sending signals for help to recruit a bunch of other white blood cells to deal with that infection or other assault. Now, bacteria is one source of inflammation that can drive these neutrophils into action. But we know there are other things that can cause inflammation that might be driving this increased number of neutrophils that we see amongst individuals with TBRS. For instance, we know that obesity is common amongst individuals with TBRS. Obesity is an inflammatory state, and so we're wondering, but we don't yet know, if that might be a source of inflammation that drives this higher percentage of neutrophils. We still have some work to do to sort that out. So what I would say is, could this increase in neutrophils be in response to increased basal inflammation that is experienced in individuals with TBRS? But again, we've got some more work to do to understand why this is, and if by itself it contributes, could be like this cycle. You've got some basal inflammation, you recruit neutrophils, they cause more inflammation, and you just continue in this sort of vicious cycle of inflammation. So I think that's a really important area of study, and one that we hope to address with some of our existing mouse models in the coming years. Okay, so another type of white blood cell we saw some differences in our TBRS individuals compared to our individuals without TBRS are the so-called blood B cells. So B cells are a type of white blood cell that when they're exposed to something that stimulates them, be it an infection or a vaccine, they can be trained to attack that infection or whatever very specifically. So if they're exposed to a vaccine or an infection, then they can produce something called an antibody that specifically just attacks that one thing. So it's a more precise way than what the neutrophil does. The neutrophil just like loses its mind and starts running around the room and setting everything on fire. The B cell says, let's be a little more precise and let's just attack that one thing that's causing the problem. So this is when you get a vaccination, you stimulate your B cells to make a specific response to that thing that you're getting immunized against. And in addition to sort of just making the cells at the time of that exposure, then you also create this immunologic memory. So you have a whole bunch of those cells that are poised and ready to attack and make those specific antibodies if you're ever exposed to that same thing again. That's how vaccines work. So what we saw in our individuals with TBRS are that they tended to have lower levels of blood B cells compared to individuals without TBRS. Again, most of them were within the normal range, just on the lower end of it, and a few fell below the normal range, but most were just on the lower end of normal. But we do wonder if this lower number of B cells could mean less antibody production for individuals with TBRS. And in looking through the registry, we see individuals with reports of frequent infections, sinus infections, lung infections, viral infections, sort of over and over and over again in their life. So it does make one wonder if perhaps these are individuals who have relatively low levels of B cells and therefore relatively low levels of antibodies to help clear those infections and prevent infections on subsequent exposures. Also makes you wonder if they're able to mount a response to vaccines in the same way that the individuals without TBRS are able to do. So again, we'll talk about some recommendations, but just something to prime your mind about. Okay, so those are the major findings. Again, for the most part, the blood of individuals with TBRS is by and large normal. Again, there were some subtle differences that I think are worth bearing in mind. We saw that on average, their red cell size was slightly larger. I think that's benign. No intervention is necessary, but probably important to know that about your loved one with TBRS. We saw higher numbers of blood neutrophils. Is this a reflection of or a contribution to or both of sort of higher basal levels of inflammation in individuals with TBRS? I don't know that there's a great way to deal with that. Perhaps weight control, if possible, might help lower that basal inflammation. I think we know that inflammation is associated with things like heart disease. So I think we know that individuals with TBRS can have some heart issues at baseline. This might contribute to it as well. So regular assessments of the heart would be important also. And then the blood
Dr.
cells.
Rao,
Sure, yeah.
I'm just going to interrupt you with a quick question from the chat, if that's okay.
Yeah, great.
Okay. Can lower B cells account for vaccines not working? My daughter has been vaccinated multiple times, but doesn't seem to have titers for these.
That would be my suspicion. Yeah. So either you don't have enough or they're not working properly. So I'm glad that they checked the titers. I think that's a good indication that the B cells aren't doing what they should be doing. So referral to an immunology doctor would be what I would recommend for that situation. That's a great question. Great, thank you. Okay, so I was just going to get to these recommendations. So I think if you are having infections that should have been prevented by vaccines, asking your doctor to check what we call viral titers, and that's looking to see that you've mounted a normal response to the vaccines you've gotten, would be advised. Also in individuals who have had infections over and over and over again, you can check immunoglobulin levels. So then you could know that you just have an overall low amount of immunoglobulin. And there are some individuals, if those levels are so low, you can actually give them immunoglobulin like through the IV or subcutaneously. So you can medicate them almost with giving them a medicine that's immunoglobulin. So replace what they aren't making by themselves. And I see a few individuals in the TBRS registry who are getting immunoglobulin replacement for having low immunoglobulin levels. So again, it sort of aligns with what we saw in our study, and it's being reported in the TBRS registry. So it's something to be aware of. I'll stop there again and see if there are other questions, Jill, that you think would be best to address now before moving on.
That's the only one I see in the chat, but does anybody have Greg, did you just put something in here? Something, if you have a question and I'm not seeing it, just unmute and you can ask. Oh, okay, I see. Sorry. There's a question that is, okay, I have CLL leukemia diagnosed as de novo. I'm currently asymptomatic. Would my son be more likely to have CLL or SLL in the future?
Okay, so I'm going to have a follow-up question first. I'm assuming the person who put that in there does not have TBRS. Is that correct?
I'm assuming that too. Yes, that's correct.
Okay, great. So we don't know overall that there is a genetic risk for CLL in particular. And we haven't seen reports of CLL in individuals with Tatten-Brown-Raman syndrome. We have seen some blood cancers, and I'll talk about the ones that we've documented so far, but that hasn't been one that has so far been reported. That's a very specific, what we call chronic leukemia, that is usually diagnosed in adults, usually older adults, not to assume anything about the person who asked the question, but it's not something that we typically see in kids, and it's not something we've seen in Tatten-Brown-Raman syndrome per se yet. So I would say I don't think that there's an increased risk for that because of either the TBRS nor because of your having had it. I don't think that puts your children at increased risk for it either. It's a great question. Oh, thank you.
Thank you, Dr. Rao. And then her daughter also has lower IgG, IgA, IgM, but she's rarely ill, so they're not giving her any intervention.
Yeah, good to know. And I don't know if they've checked her, by vaccine titers, but if she's got overall low levels, maybe a good idea to check and make sure she's mounting an adequate response. Now, just because you have relatively low levels of immunoglobulin doesn't mean the ones you have don't work properly. So it's great that she's not getting infections, but something to be aware of, so that if she ever encounters a severe infection, it may be something that she might benefit from, that immunoglobulin replacement therapy.
Thank you, Dr. Rao. I think that's all for now.
All right, so I'll go on to the next little part here. Okay, so I mentioned at the very beginning, the reason I first was interested in DNMT3 is because it was found in the leukemia cells of people with certain types of leukemia. So that was the other thing that I think has been a big wonder in the field, is, are individuals with TBRS at increased risk for blood cancers? We have seen reports of blood cancers in individuals with TBRS, and I'll just sort of walk through the ones that we have known about so far. So one of the first reported, a couple of the first reported were in adolescents, or near adolescents. So a 12-year-old with acute myeloid leukemia and a 15-year-old with acute myeloid leukemia. And I've just documented the mutations that those particular patients had. So one was an R735S and one was an R882 mutation. There's also a 6-year-old girl who had a blood cancer called T-cell lymphoma. That girl had a different cancer when she was younger, and that cancer's treatment can be associated with secondary cancers later in life. So there was some question about whether that lymphoma was more due to her DNMT3 mutation or to the therapy she had gotten for her first cancer. Nevertheless, it's one of the ones that we've reported in an individual with TBRS. There was also a very nice paper published a few years ago collating those cases and additional ones that had been discovered. Again, we see sort of that pre-adolescent time, so another 12-year-old with acute myeloid leukemia, a younger child with a different type of leukemia called B-cell acute lymphoblastic leukemia, which is actually the most common cancer that we see in children, and then an adolescent with acute myeloid leukemia, and then a lymphoma, and then a very rare type of blood cancer called essential thrombocytosis. This is super rare and usually happens in older individuals. So the fact that it occurred in a younger person, a 34-year-old, does suggest it may be related to the DNMT3 mutation. And then in addition to these, there's a very rare type of skin lymphoma called mycosis fungoides that was reported in the TBRS registry in an individual who was 20 years old. So how high is the risk for getting a leukemia blood cancer? So I just walked through the ones we know about, and that's 9. Are those all of the ones that are out there? We don't know. And how many individuals with TBRS are there? We also don't know that. So we don't even know the numerator, we don't know the denominator. So it's too early to say what is the absolute risk for the development of blood cancer in individuals with TBRS. Again, we know that there are hundreds of individuals with TBS, if not probably thousands, but I think, again, I'll just reiterate, I don't think that most individuals with TBRS will never have a blood cancer. But this number is higher than the expected population incidence, which is about 1 in 100,000. Okay, so this is higher. How much higher? We don't yet have evidence to say. What we can use, we can't look at every individual in the world with TBRS because we haven't found them all, but we can generate lots and lots and lots of mice with the same mutations. We can use these as tools to study things like we can get more individuals to look at their blood, and we can follow them over time to see what's the relative chance of developing a blood cancer. And there are a number of mouse models. We've looked at 3 different ones. And there are 3 major parts of the DNMT3A protein, each of which has a different function. And we can see mutations, these are just the TBRS mutations, in each of these 3 functional domains. And so we wanted to generate mice that sort of recapitulated each of those different types of DNMT3A mutations. So we had a mouse with a DNMT3A mutation in this blue part called the PWWP domain, which helps guide it to the right places in the DNA to do its job. Similar to the ADD domain, we wanted to have a mouse that had a mutation in that domain. And then Tim Lay's group had a mouse in the methyltransferase domain. So this is the mutation that is the same as the 882 in humans. The mouse's protein is slightly different, so the number is slightly different, but that's the same mutation as this R88 mutation in humans. And then we had a mouse in which we just deleted 1 copy of the entire gene. So we've got 1 normal copy and total loss of the other copy. So we've looked at these 3 models, and then Tim Lay's group published a beautiful paper about mice with this particular mutation. So I'll walk through what we saw there. So the first and foremost is, do these mice look like individuals, humans with TBRS? And so we wanted to make sure that they had sort of the overgrowth phenotype of individuals with TBRS, and we saw that they do. So they tend to get larger in size, both males and females, if they have the DNMT3A mutation, compared to if they do not. And you can see that visually here in a picture of a mouse with a DNMT3A mutation compared to its sibling mouse that didn't have a DNMT3A mutation. It's both sort of has more weight, and it's hard to tell in the mice, but it's longer if you measure from here to here. So it would be taller if you were a human and stretched it upright. So that's a good start. We know that these mice model sort of the overall phenotypes that we see in humans with DNMT3A mutations. So what do we see in their blood? Well, that was somewhat reassuring. We saw that, like the individuals with TBRS that we had studied their blood, that the mice, we looked at these 3 different types, also had bigger red blood cells compared to their sibling mice without the DNMT3A mutation. They had higher numbers of neutrophils, just like the humans that we had studied, and they had lower numbers of B cells. So they look both sort of visually in size to be similar to individuals with TBRS. And we've done some behavioral studies as well, where we see similar features. And their blood looks very similar to what we'd seen in our humans with TBRS. So we think this is a very good model to study many things about TBRS. We wanted to ask, if we leave these mice and follow them carefully throughout their lifespan, what percentage of them develop cancer? And what we found in our study and in multiple studies done by Tim Lay's group is that you do see a higher rate of blood cancer in the mice with the DNMT3A mutations compared to those without. But the incidence varied between models, and a vast majority of mice did not develop cancer. In the range of 10% or so of the mice overall developed cancer, and most of those happened when they were super old mice. So we didn't see a lot of leukemia development in younger mice. It was, in a very small minority of the mice did we ever see any type of cancer. So I'm just gonna sort of go back and say cancer is not an inevitable consequence of having a DNMT3A mutation. That's my start and that's my end. But I do think it's important to know that we did see higher rates of those cancers in the mice, and we get a sense from humans in individuals with DNMT3A mutations compared to those without. So what do we do? I get this question all the time. Well, how do we monitor? What do we do? How do we check? So even doctors haven't reached agreement, and you're going to get some disagreements even amongst experts in DNMT3A. But the problems are there's no great screening test for leukemia. Even if there was, there's no early treatment. It's not like breast cancer. If you find a lump early before it spreads to the rest of the body, you have a better chance of curing it. Leukemia at diagnosis is by default all throughout the body because it's our blood. Our blood goes everywhere. So there's no early treatment. There's no great screening test to pick it up early. And even if you did, you wouldn't change how you treat the patient. It wouldn't impact the outcome of the patient. So what I say is the most important thing is to know the warning signs so that if leukemia develops, you'll seek medical attention appropriately. So I'm going to walk through just some tips and tricks for what that might look like in an individual in the unlikely situation that your loved one with TBRS develops leukemia. Oops, I went too fast. Okay, so I mentioned at the beginning, all blood cells are produced in the bone marrow. And so leukemia typically arises in the bone marrow. The leukemia cells just by nature grow much faster than our normal blood cells. So they ultimately crowd out all of those normal blood cells, making it hard to produce enough to do all the things those cells should need to do. So if you've got too many leukemia cells in there, then you're probably not making enough of those red blood cells, the cells that carry oxygen to all of our body. So you're anemic. You're very pale skin. And I know many individuals with TBRS sort of at baseline have relatively pale skin, but this would be an appreciable change. This is one of the more common symptoms of leukemia that I see in my patients that I treat in clinic, and I call it the grandma test. You've got a kid who's been gradually getting paler and paler over weeks to months, and the parents don't notice it because it's a gradual change. But grandma comes over, she's like, oh my gosh, that child is pale. Like, you need more vegetables or something. It's really it's something that can happen kind of subtly over time, but it's apparent if you really look back and see what their skin color was. So it would be a pretty significant change. Additionally, if you're anemic because you don't have enough red blood cells, you're very fatigued, like more fatigued than normal. You can't walk here to there without getting winded, without needing to sit down, just can't get out of bed, that sort of fatigue. Having severe anemia can also cause very severe headaches that just will not go away. And then again, getting short of breath more easily than normal. If your body isn't able to produce enough of the blood platelets because you've got too many leukemia cells crowding them out, then you're at risk for bleeding. So that can be, my gums are bleeding now when I brush my teeth. That's never happened before. I'm getting nosebleeds, but not normal nosebleeds like the little ones that stop with a little bit of pressure. These are gushers, right? The ones that just, you have a real hard time stopping. Or if you're getting bruises in places you can't explain, like there's no way I hit my back right there. It's hard to explain that bruise. Or bruises that you can feel, right? Bruises should be flat things that you see, but if they're really severe bruises that you can feel, that would also be abnormal. And then, of course, if we're not able to make our infection-fighting cells, then we're at risk for infections. So having persistent fevers that just will not go away, severe infections, not just a little cold, something that lands you in the hospital. And then because all of these leukemia cells are being made in that hollow part of the bone can just be, there can be an increased pressure in that hollow space that causes bone pain. My child usually walks, and now they're refusing to stand up. They can express bone pain by saying it hurts, but can't really pinpoint where. That would be abnormal. And then there's an organ in our belly called the spleen, and that can get really filled up with leukemia cells. It's sort of like a sponge. And if that gets really big, it's right by the stomach. So you just can take a couple of bites and then you can't eat anymore because you're full because that spleen is compressing the stomach. That's another possible presenting sign of leukemia. Okay, so some other findings that are better shown visually. This is a special skin finding called petechiae. Petechiae are those little micro hemorrhages, bleeds into the skin. And the difference, we can all get rashes that kind of look like this. But usual rashes, you press on them and they get white. This, if you press on them, they stay red. So what you can do is take a cup and press a glass, I shouldn't say a cup, a glass that is, you can see through it, and press down on the skin. And if the skin gets white, but those things stay red, that might be petechia. That's a sign of low blood platelets. Swollen glands, leukemia can fill up the glands, the lymph nodes in your neck. That would be something that you'd want a doctor to check out. And then this is a rare situation, but I pointed out because it is something that we can see that is characteristic of a type of AML that we've seen in individuals with TBRS. And that AML can infiltrate the gums. And so I've seen this in non-TBRS individuals, and these patients are often sent to a dentist first. But if you see this type of gum swelling, that's something that could be a sign of leukemia. Now, what I'll say is usually these symptoms don't happen one at a time. Usually you have multiple of these symptoms all at the same time if you have leukemia. So if you see something like this in the gums, you probably also have the petechia, the really pale, feeling fatigue, having fevers, things like that. But it's just something to be aware of because, again, I've seen lots of kids sent to a dentist for this finding before a physician. Okay, so if any of these arise, I would suggest having your doctor get laboratory test, a complete blood cell count. It looks for how many red blood cells, white blood cells, platelets do you have? And that would show anemia, so very low red blood cells and platelets, usually a low platelet count. And then the white blood cells can be either low, because you're not making enough normal ones, or high, because leukemia cells are detected on the complete blood cell count as white blood cells. So if you have lots and lots of those, they're out in the blood and you see a high white blood cell count. And then that might flag it as having abnormal white blood cells called blast. Okay, so last time I gave this talk, some questions had been submitted ahead of time. And so I just wanted to keep a few of those in there. One was, can leukemia be cured, which I think is really important. So in the unlikely event that your loved one with TBRS gets leukemia, we have excellent therapies available. We do not cure every patient with leukemia, but we cure most children and adolescents who are diagnosed with leukemia. And if you look through those reports, most of the individuals with TBRS who have been diagnosed with a blood cancer have been cured, which is great. That said, the therapy is extensive and it's hard to go through, but it is effective. So all patients with leukemia get treated with something called chemotherapy. These are medicines that can kill the leukemia cells. They do come with side effects. I'm not going to go into the details of that because what type and how much would depend on the type of leukemia that your loved one would be diagnosed with. Immune-based therapy, so this is something that's relatively new, but it's essentially leveraging the patient's own immune system to help fight the cancer. In addition to fighting bacteria and viruses, our immune system is actually pretty good at fighting cancers. So we've now come up with ways to sort of use the patient's immune system to help fight the cancer, which is pretty cool, I think. Very few patients with leukemias need radiation, but very specific situations require it. And then some patients with certain types of leukemia might need something called a bone marrow transplant. And that just means the best way to get rid of that leukemia is to wipe out everything in the bone marrow, giving very high doses of chemotherapy, sometimes radiation, and then giving a new blood system altogether from a bone marrow donor. So I'm just going to put a plug in. Join Be the Match. So the way we find donors for many of our patients who require bone marrow transplant is through the National Marrow Donor Program. So you can search Be the Match, and it's just a simple cheek swab you can send in and get in the match. Okay, so what about other cancers? This was not included in my last talk, but I think it's really important to talk about because as the registry has matured, as the literature has matured, we found some case reports of individuals with TBRS developing other non-blood type cancers. And I'll talk about 3 of those. So the first is a cancer that we see in children called neuroblastoma, and there have been 2 reports so far, one in the literature and one in the registry. There's been 1 individual in the registry and now in the literature reported with skin cancer, and then 1 individual in the registry who's reported breast cancer. Yay, registry. This is how we found a lot of these patients, very important. Okay, so neuroblastoma, this is a cancer of mostly young children. Almost everybody who has neuroblastoma is diagnosed before they reach the age of 5, very rarely in individuals older than that. This is a cancer that arises from immature nerve cells, and it's usually nerve cells in the part of the body called the adrenal gland, which is a little organ that sits on top of the kidneys. So right here in the abdomen. It can occur in other places because we, of course, have nerves throughout our body. So it could be in the neck, chest, other places, in the back, other places. The symptoms of this would be a lump, usually in the abdomen, but could be in the neck or chest. This can also metastasize to the bone. So it can get in the bone, even if it started in these other places. So you can have bone pain there as well. It can cause a very specific type of syndrome in children. where they have this sort of dark discoloration around their eyes, and eyes can be bulging, usually because of metastasis to that part of their body. And then because it's a cancer of the nerve cells, it can cause a pinching off of the nerve cells, so you get weak, you can't move a part of your body because you've impacted the nerves that go to that part of your body. So again, there are two so far, one in the registry and a child less than 1 year of age at the time of diagnosis. So that's when we would expect it to be diagnosed, just generally. And then in the literature, an 18-month-old who was reported to have a special type of neuroblastoma. And that's the girl who later in life had a T-cell type of leukemia. So what I'll say is I don't know if these two cases are enough to say that individuals with TBRS are at higher risk for this rare cancer compared to other children. I think we need more data on this. I think we need to get a better handle on if this is common in individuals with TBRS. I looked through kind of there's a lot of studies looking at the genetic changes in neuroblastoma cells, and there isn't a single DNMT3A mutation, which to me, if there were other individuals with TBRS who had neuroblastoma, they would have popped up there. We would have seen their DNMT3A mutation there. So I still think this is going to be exceedingly rare, but I think we need to keep it on the radar. So I would say routine screening for this is not currently recommended. There are two different, very rare genetic syndromes that we know predispose to this very highly, like 50% of those patients will have neuroblastoma. And so they have general screening guidance that includes physical exams on a regular basis, urine tests that can help detect this, ultrasounds, chest x-rays, until they're 10 years of age. I don't think we're there yet, but I think we need to get a better handle on how often this happens in TBRS individuals. So I think we're getting there, and it's great that we've got child in the registry, but I'd love to gather some more information on this. Skin cancer. So a very recent paper published just a couple years ago reported an individual who was also in the registry who had, at 25 years of age, a very rare skin cancer called a dermatofibrosarcoma on his back. That's not really like a skin cancer like we think of, but it was surgically removed, and we don't have more information on that. But then when the same person was 34 years of age, he was diagnosed with melanoma, which is a so-called malignant type of skin cancer. By malignant, I just means it can spread to different parts of your body from where it started. And this is a picture from that paper of what that lesion looks like. So it kind of looks like a mole, but kind of an ugly mole. So this is one individual. There may be more, we don't know. So again, I think it's too soon to say that individuals with TBRS are at high risk for skin cancer, but I think there are some very easy and very reasonable actions that we can take. UV protection, I think this is important for all of us, but perhaps more so for our TBRS patients who do tend to be pale, and being a little bit, having a lighter skin tone predisposes you to skin cancer. And if having a DNMT3A mutation also does, then let's take some extra precautions. So good sunscreening, reapply every 2 hours, use a high SPF, avoid prolonged exposure to the sun, avoid those really intense 10 a.m. to 2 p.m. periods when you're out at the beach. No tanning beds for anybody, much less a TBRS patient. And certainly no smoking for all of us, but probably really important for our individuals with TBRS. Skin checks, monthly self-exams. So you're going to need a mirror. You're probably going to need a partner. You need somebody to look at your scalp, look at your back, look at your butt. Just checking out things. Once you've done that thoroughly, then you'll sort of have these places that you can follow. If there's like a mole that has been there and you just want to keep an eye on what it looks like. But monthly is what I would suggest. And then regular. So I got these, mostly I looked at making sure I was aligned with things like the American Cancer Society and the CDC. And they just say regular skin checks by a doctor. I would say yearly is very reasonable. You go to your doctor pretty much yearly anyway. Have them do a thorough skin check. If there's something suspicious, be referred to a dermatologist. Okay, what to look for? New, expanding, or changing. New, expanding, or changing. Those are sort of the key words. So a mole that's new, never been there before, just all of a sudden cropped up. Or if you've had one there that's now changing in size, shape, color, it's going from flat to not being flat. Any mole with an odd shape. They should be kind of circular, but if they're kind of a jaggedy, weird shape, irregular borders, or areas in which the mole looks darker in one part, lighter in another, that's probably abnormal and needs to be looked at. If you've got a sore that bleeds and doesn't heal after several weeks, that's abnormal. Rough or scaly red patch which might crust or bleed, or a wart-like growth should be evaluated by a physician. And I just wanted to throw in some pictures that I pulled from the American Cancer Society. You can peruse their website and find some other terrifying images, but these are some examples of melanoma. So this one, irregular border, raised. This one isn't as scary, but see how it's lighter in the middle, darker on the sides, has kind of this indiscrete border on the outside. If you see something like that, have it checked out. Again, here, doesn't look terrifying, but darker here, raised, lighter here, just some signs and symptoms. They can even be in sneaky places. This is on somebody's heel. So those skin checks, you gotta look everywhere. We have skin all over our body. So we need to be looking at all the places. Okay, and then I'll wrap up. There's one woman in the registry who was diagnosed with breast cancer at the age of 40. It's not clear, breast cancer is relatively common cancer. So it's not clear if this is associated with the DNMT3A mutation or just having two bad things, at the same time. I think I would just recommend typical screening. And what that means depends on which organization you look at. There's slightly different recommendations from the CDC versus the American Cancer Society, but in general recommend starting with yearly or every other year mammography beginning at the age of 40 or 45. And I think that's very reasonable. Okay, so I'll just conclude there by saying what we found in individuals with TBRS is that their blood is largely normal. There are very subtle differences that I think are just important for awareness. Again, the immunoglobulin may be actionable. Increased red cell size probably isn't. So know you're normal. When you're feeling perfectly healthy, well, have a routine CBC done just to see what things look like at your normal baseline. Cancer is uncommon. Most individuals with TBRS will never have cancer in life, but recognize the warning signs. Oh, and then if you haven't done so yet, please participate in the TBRS registry because we have a lot more to learn. And with that, I'll stop and take any further questions. Oh, and there's my contact information should you want to reach out after the session's over.
Thank you so much, Dr. Rao. That was really digestible, family-friendly material, and I appreciate what a great job you did delivering that information to us. And I'm going to just reiterate and thank, I see people in this call who have completed the patient registry, which is so important, not only to understand our kids' cancer risk, but to understand TBRS as a whole. And I think it's probably the single most important project that we've done at the TBRS community. And I also want to acknowledge how hard it is to complete the registry, especially when you have a loved one who has cancer or they've gone through cancer. It's really emotionally challenging, to say the least, to revisit all of that information. And I can't imagine what that would be like if you have lost your loved one to cancer. So if anybody in this call has experienced a loved one having any type of cancer, any kind of condition that they feel like it's too overwhelming to complete the registry, but they'd like that information to be captured, please reach out to me and we'll figure out the best way to do that. For example, I know of two people with TBRS that, one of the cases Dr. Rao went into, and then the other case was 36 years old. Both of them passed away from melanoma. And then there's another person who was diagnosed who was very young, but so it's really important to capture everybody's experience, and we'll understand TBRS and be able to be more proactive the more we know. So that's my 2 cents. Thank you, everybody who has contributed, and acknowledging how hard it is to do that, especially when you've gone through something like cancer.